Okay, welcome to the National African American Child and Family Research Center's Research Capacity Building webinar. My name is Latrice Rollins. I serve as the director of the center, and this has been an awesome series every month coming and sharing about various research methods, various studies, particularly centered on our programs with the Administration for Children and Families, and also with a focus on community engaged research as well. And so for the Administration for Children and Families programs at the National African American Child and Family Research Center, we focus specifically on the Temporary Assistance for Needy Families program, or TANF for welfare. We focus on Head Start and early Head Start programs, as well as child care assistance programs. And so our speaker today, Dr. Arthi Rao, I'm going to stop sharing so that I can introduce you properly. So our speaker today, Dr. Arthi Rao, she is a senior research scientist and interim director at the Center for Quality Growth and Regional Development at Georgia Institute of Technology, or better known as Georgia Tech. She has had a consistent focus on health and place throughout her career. She has an interdisciplinary educational and professional background in urban planning, epidemiology, and geographic information systems, or GIS, which you'll hear about. She really focuses a lot on the social determinants of health, healthcare access, healthy communities, and of course, spatial methods. She uses advanced spatial analytics and data science methods for her research, and also works to create data decision support tools for academic and industrial applications. She is a co-investigator here at the National African American Child and Family Research Center and has helped us in our understanding of using spatial analysis for the ACF programs. And so we are honored to have her, and I will turn the floor over to Dr. Rao.
So welcome everyone, and thank you for joining us. As Dr. Rollins mentioned, my name is Arthi Rao, and I am a senior research scientist at Georgia Tech. So I'll start by saying a little bit about my work in general and how we can take some lessons from these research and research applications and use them, for example, to analyze ACF data. So as Dr. Rollins mentioned, I have a fairly interdisciplinary background, but what has stayed consistent throughout my education is this interest in connecting health and place. And if you look at the various, academic credentials that I have in each of those areas, I have a pretty good understanding of the connection between health and place. So multiple scales, like, so in architecture, for example, I have looked at healthcare settings and hospital design and landscape architecture, thinking through what therapeutic landscapes mean, what healing means. And then in urban planning and epidemiology, through my Ph.D., really get a very quantitative understanding of how to measure this connection between health and place, and of course, using geographic information systems to conduct spatial analysis. If I were to think through the research that I do, I would put them in three broad buckets. So you've heard me talk about place and health. This includes things like assessing neighborhood effects on health. For example, why does place matter and how does it matter? Something that we're still working on the scientific side is how do we quantify things like dose response when it comes to place and health research. So for example, does the quantity and the quality and the configuration of green space impact health outcomes? Another area of health and place research is health impact assessment. And if you potentially attended the webinar last month on equity impact assessment, I presented with the other co-investigator, Dr. Brian McGregor, where we talked about equity impact assessment and in the context of other models such as health impact assessment. So you may have gotten a background on what that means, but spatial methods contribute in HIAs as well. The other area that I look at is how do we use smart technology make places more equitable, because we know that technology can reinforce existing divides in communities, right? So my objective is to do exactly the opposite, which is how do we use smart technologies to bridge these divides. So I have a current NSF grant that is looking at health equity in communities, using and how do we measure it, and how do we optimize it in communities using smart technology. I've also created geospatial decision support tools, both in industry as well in academia, to help organizations make strategic decisions around resource allocation, intervention design, and geospatial tools are a great way to look at disparities and address disparities and be very focused in how we identify vulnerable populations and how do we help them. In terms of teaching, I teach 2 classes in public health. I teach the built environment public health class in the fall semester. And this is cross-listed with Emory. So I have a really nice interdisciplinary setup with Emory public health students and Georgia Tech urban planning students, where we collectively look at built environment and public health and the concepts and their mechanisms. And in the spring, whenever it's offered, I teach a class called Public Health Analytics, which takes the concepts that I teach in the fall and translates them into spatial methods to investigate the connection between health and place, with a predominant focus on applied statistics and spatial analysis. So with that background, let's take a quick look at what I'm hoping to accomplish today and present to you. So the first part of the presentation is really giving you a background on why place matters, right? Why do we care about place? How is spatial analysis used to describe place and measure that connection? And within that context, what are geographic information systems? Then I will show you some examples of current analysis that we are doing with data from the Administration for Children and Families. And these examples mostly focus on TANF data, or the Temporary Assistance for Needy Families data, because it's a fairly data-rich environment. We've had some time to explore it, but these methods that I show you are equally applicable to other ACF programs as well. I will also leave you with some background and food for thought on, what are some of the challenges, the pros and cons of certain methods, certain scales, et cetera. So you have a background on how to use it in your own practice and some things to think about when you make decisions for how you want to do your analysis. So I'd like to start with this first set of slides in giving you a background on why place matters. So I'd like to tell a little story, and this is always, my students really get engaged with this topic, where I want to take you back to the 1800s, back when industrialization and urbanization was at its peak, right? The background to this is, at that point, we really didn't know what caused disease. We thought that disease was a result of these kind of poisonous gases that were coming out of the earth and contaminating the air and causing people to get sick. This is called the miasma theory of disease. And the origin of the miasma was what we call undesirable places, right? Things like cemeteries, sewage, garbage, area where people disposed of their trash, which in the 1800s was pretty much anywhere on the street, because we didn't have organized sewage infrastructure, and we did not have organized trash disposal systems. And then, things like marshes and bogs, these were all what we call undesirable places, right? So the notion was that people were getting sick because of the miasma that was exuded from these places. And the other thing that was supporting the idea of people getting sick was, because of railroads transporting a lot of people, there were a lot of people migrating into the city, right? So we start to see some very polluted environments because, there wasn't any regulation around how industries were organized with respect to where people lived. We see poor housing conditions. We see a lot of overcrowding. You must have heard of tenement living. We see a lack of sanitation, like I just mentioned, and we also didn't have very well-designed, buildings, right? Because there was no regulation or ordinances around what a healthy building looked like. So all of this is very conducive to the spread of disease, and we see huge infectious disease outbreaks like cholera, typhoid, and tuberculosis. So the medical community decides that we need to do something about this. And so they, for the first time in history, we see a formal collaboration between the health community and the engineering community or the urban planning community to figure out how to fix this problem, right? And so some of the responses included what we call sanitary engineering. So for the first time, we developed large-scale sewer systems that moved sewage efficiently away from living areas, and formal methods of waste disposal, so people were not exposed to this miasma. There's also, on the other hand, methodologically, we see systematic data collection, or the ability to track where cases were emerging, and also what the environmental conditions around those cases were. So how do we then see this connection, again, between place and health? What are some of the place-based responses? So we start to see what we call housing reform, right? Where we have building ordinances, where buildings now are required to have lighting, fresh air, sunlight, ventilation, fire escapes, things like that. So to make housing healthier. We see zoning, or we see the idea that we are separating so-called unhealthy land uses from healthy land uses, right? So industry is meant to be separated from residential, so people are not exposed to the smoke, the pollution, and other hazards that come from industrial land uses. And then we have a very big reconfiguration of the city through the City Beautiful movement, where the city is now meant to evoke civic pride. It is meant to elevate people morally, spiritually. So we see the construction of these beautiful monuments. The World's Fairs were held. We see beautiful parks, landscapes. And so the idea is that it is supposed to be both emotionally, spiritually, and physically healing. It's supposed to elevate a human being in all of these spheres to make a healthy place. Fast forward, we go to the early 1900s, and we then see that scientists discover that it's not miasma that's making people sick. We actually have pathogens that we can look at under a microscope. So now what happens is a disconnection between place and health, because now health is about a particular bacteria or virus. So the focus is on developing chemical therapeutics in the form of vaccinations, antibiotics. So there we start to see the separation from the social model to the medical model. And for those of you who are not familiar, this is one of the first what we call spatial epidemiology maps developed by John Snow that tracks the cholera epidemic in London to this one water pump. And it's kind of the first map where you see a dot density map, where you see that the larger black areas are where there have been more cases. So this is the first kind of cluster detection map that, if you can, for lack of a better term, but we see the first kind of roots or foundations of spatial thinking and tracking disease and place. So, like I mentioned, we've now recognize that it's germs that are making us sick. We've created vaccinations and other chemical therapeutics to get people better, right? So we've brought contagion and infectious disease under control. But now what we're seeing in the late 1900s and even now is that the distribution of the leading causes of death have changed. So if you look at the the bar graph that I have on the right side of the screen, the 1900 shows you the distribution of the leading causes of death. And if you see that, they're mostly infectious disease. But when you turn your attention to the graph in 2010, you're starting to see that they're all chronic diseases, right? So it's no longer enough to just vaccinate people and give them medication. So the WHO and the other leading, global health organizations start thinking about how do we define what health is. So they come up with this new definition in the late 1900s that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, regardless of race, religion, political belief, or economic and social condition. So two important themes here. One, health is not just not being sick. And two, there's an equity statement here that says that everybody deserves to be healthy. Okay, so two very important themes in this paradigm shift of thinking about what health is and what it should mean. And that brings us to what we call the socio-ecological model of health. Okay, so let's quickly backtrack. So we've seen the story of how health and place were considered very closely aligned. Then we see kind of that breakup. And now we're seeing the rejoining of the place and health model, where they're saying that it's not just enough to be where it's not just enough to be not sick, but you need to be healthy, and everybody has a right to it. So it's not enough to just make this a personal responsibility, right? So now there's the realization that it's not just the individual traits that determine whether you're sick or not. It's about everything that's around you, right? So you might have heard the notion of the zip code is a better predictor of your health than your genetic code. And that's exactly kind of the new wave of thinking, which is the socio-ecological model. Through its population and multi-level approach to health, ecosocial epidemiology recognizes that extra-individual socioeconomic factors closely related to the physical and social infrastructure of communities affect health above and beyond a combination of individual risk factors. So the socio-ecological model is a multi-level model, as you can see in the diagram on the right, and it's a nested model. So we start with individual characteristics and slowly start rippling out to look at the various layers of the onion that need to be peeled to really understand what keeps people healthy or sick. So the next level above the individual characteristics is the interpersonal environment. So what kind of social support does a person have? What kind of friends do they have? What kind of networks do they have? Because all of this determines a person's access to resources, information, and really, the kind of the social learning that happens. So, for example, we know that social contagion theory shows that, for example, your health habits are very close to the friends you keep. So, obesity is attributed to social contagion. Because what you eat, how you exercise, and the lifestyles you pick are to a large extent learned from your peers, or your parents, or your family. So whatever that might be. So then the next level is the neighborhood environment, which is where you live, where you work, where you play, where you buy food, where you take public transit, where you go for a walk, where all of those things. And then the next level is about thinking through kind of the macroeconomic determinants, which is how our policies, our politics, racism, all of that, because what that does is determines how resources get distributed in the neighborhoods. So, for example, we've all heard of redlining. So redlining is a macro social determinant, which then determines that certain neighborhoods get investment and they're resource rich, and certain neighborhoods are disinvested. So they don't have the needed resources to support health. And all of this goes to say that this is a very simplistic explanation is, if you get sick and you go to the doctor and the doctor gives you a prescription to manage your weight and say, you've got to eat healthy, you've got to walk so many miles a day, and then you go back home and you live in a neighborhood that has a high rate of crime, no sidewalks, nothing to walk to, so no destinations to go to, only fast food restaurants and no grocery stores. How are you supposed to follow through with that prescription? So that is the whole idea. The fact is we need to take into account the person and their context in evaluating their health. So I'm trying to see how we're doing with time. I think I should speed up a little bit. But I just have a slide here again explaining what the social determinants of health are. And the way I like to look at it is it's a cumulative causative circular causation model where macro-social policies influence the configuration of the physical built environment, which then sets off social processes, which I call social determinants, right? And it just keeps, like I said, circular causation. It just keeps reinforcing each other. So let's look at place as a predictor of health. So this map on the right shows you life expectancy data in census tracts, which is a census-based geography nested within counties. So it's a sub-county geography. And if you see, so the red census tracts depict the lowest of the range, and the dark blue depict the highest of the range, right? So you're probably thinking, oh my gosh, why do we have such a huge disparity in life expectancy? And you'll see certain areas where there's blue kind of juxtaposed with the red. So you're like, why are two census tracts that are so close by so different? Now, the biggest predictor of death is age, right? And we just looked at the socio-ecological model. Now, it's highly unlikely that everybody with the same genetic composition is living in the same place. What I mean by that is areas that have low life expectancy, it's highly likely that those areas have people with the same exact genetic composition, right? Because we know that's not true. But what we do know is that social conditions cluster in place. So if there's a neighborhood that has high number of vacant properties, high unemployment, high crime rate, it's all likely to occur in the same neighborhood, right? And so when that happens, it creates a clustering of concentrated disadvantage at the neighborhood scale. Now, what that does is then influence the spatial clustering of diseases. So the spatial clustering of social factors determines the spatial patterning of disease. Now, because we're seeing this spatial patterning, traditional statistical methods are no longer good enough to help us explain these relationships, because traditional statistical relationships assume what we call the independence of observations, which means that when you do, for example, a regression model using tabular data, you assume that the tract next to you has no connection to the tract you live in. And that is very far from the truth. The idea is that spatial processes diffuse, and places that are close together are very similar compared to places that are far apart. When that independence of observations assumption is violated, you need a very separate suite of tools that is very sophisticated to be able to handle that spatial patterning and account for those spatial biases that arise. So here we go, and here comes GIS, right? So GIS is a means to an end. What a GIS system does, or a geographic information system does, is it links spatial data with tabular information and enables a person to visualize patterns, relationships, and trends. This process gives an entirely new perspective to data analysis that cannot be seen or detected in a table or list format. And the diagram here basically shows you all of the different components that go into a geographic information system, right? So I want to call your attention to the data category. And you'll see a wide variety of data that can be used in spatial analysis. It can be vector data, can be raster data, and then all of those data sets have attributes associated with them. So it's really a combination of spatial data and tabular data that helps you undertake these very skilled and special analyses. So I'll take the example of spatial epidemiology and to demonstrate an example of how we use spatial analysis in public health. So spatial epidemiology is a specific, I would say, a subcategory of epidemiology in general that involves the description and analysis of geographic variations in disease with respect to demographic, environmental, behavioral, socioeconomic, genetic, and infectious risk factors. Okay, so the idea with spatial epidemiology is that they acknowledge that disease occurrence is not aspatial, which means it is rooted in spatial patterns. It is rooted in spatial processes. And so, like I said, we need special methods to be able to understand if there's a geographic pattern, where is the pattern happening, how far does the patterning go, so how far does things like clustering, how big is the cluster, right? Why do we have this cluster? What are some of the place-based factors that might be impacting this cluster? And so on and so forth. So we have statistical tests, we have spatial models to be able to conduct this type of analysis and detect these geographic patterns. So I then want to move on to some of the analysis we've been doing at the center using some of the administrative data from ACF programs. So when we started with the center, we kind of went through a brainstorming session in terms of, what are the different methods we could use and how they could be applied to investigate some of the pertinent questions we were asking at the center. So as with any type of data analysis, the first step is to undertake what we call exploratory data analysis, which is descriptive mapping, understanding geographic distributions, detecting clusters, if any. And then we go on to confirmatory modeling, which includes, things like generalized linear models, spatial regression, geographically weighted regression, multi-level modeling, right? So these are more sophisticated techniques to really kind of integrate health and place, so we understand individuals in the context of their environments. How do we apply these methods? So the first step in mapping is just data visualization, right? We want to see what the data looks like. Are there any apparent patterns that are readily perceptible when we just look at maps? Where are the high values? Where are the low values? So we want to see that. And then how does a county or a census tract fare with respect to its neighboring counties or census tracts, right? We want to assess disparities in outcomes of interest. So if there's an outcome of interest, such as poverty rates or access to jobs, we want to understand which areas have good access and which areas have poor access, right? So we want to understand that. We want to measure the social determinants of health and well-being. So we want to look at things like unemployment. We want to look at things like insurance rates or other types of factors, housing burden, transportation disadvantage, because we want to see how people are, what are some of the root causes of people even being reliant on public assistance programs? What's causing them to need that help? And also, what areas need the most help, right? So which areas should be priority in dispersing additional resources and improving service delivery, right? Where are the most vulnerable populations? I've already talked about this. We're also thinking about, how do we measure access to service and resources? Do people have equitable access to jobs, healthcare, healthy food, transportation? Again, measuring the impact of neighborhood factors on outcomes. So, for example, how does job accessibility influence individual level employment rates, or the ability to utilize healthcare, for example, and so on and so forth. So these are just some examples. So I'd like to start with the descriptive mapping. So the first step, and this was data that we were able to access through a proprietary database through the ADRF that was made available through a partnership with the center and Coleridge to give us data at the sub-state level. So data at the state level, and you'll see that in a second in another study that we did, is readily available, publicly accessible, but we were not satisfied with just looking at state level trends, because if this is supposed to be a geographically informed analysis, we want to see what are the disparities within states, right? So we were able to get, TANF recipient counts by county and zip code. I'll discuss that in a second, but this is just the first cut at the data. So that we had certain states that were of interest to our study because, we already know that there's a high percentage population of African-American TANF recipients living in those states. So we picked those states very purposefully. And we did these, descriptive maps to show us where there's a high percentage of African-American TANF recipients. And then we can compare this across states. But we can also compare this over time because we have 4 or 5 years worth of data. So we can look at areas that are getting worse over time, right? So for example, I'd say from this assessment that the areas of need are staying fairly consistent. I mean, it's not a one-to-one correspondence, but the high need areas are staying fairly consistent. The next analysis that I would like to talk about is one of the first, before we even had access to the ADRF data, we were just doing a what we call a data audit, and we were looking at what kind of data we already have access to. So this was administered data that we pulled off the website, the ACF website, just to look at what are the changes on a month-to-month basis in TANF participation during the COVID pandemic. Again, the idea is not to pay attention here to the results, but to show you what types of analyses are possible and what are the outcomes or products of the analysis. So the research question we were really looking at is how did TANF participation rates vary spatially and temporally with the advance of the COVID-19 pandemic? So this is a pretty compelling graphic, which shows us the trends of TANF participation over a 12-month period in 2020. And we were able to get, like I said, TANF counts for every month for every state directly from the TANF, from the ACF website. And you can see the red line that shows you the 12-month trend, okay? And what we're trying to show here is the TANF to poverty ratio, which is a pretty commonly used metric to measure TANF participation, which means out of the people who are potentially eligible for TANF, how many people are actually getting the help, okay? And so there's a lot of implications to a low TANF ratio. So for example, it could potentially mean, without further investigation, that there are a lot of people who are in need, but very few are reaching out for help. That is one potential implication, but the thing is, it's very nuanced. The story is very nuanced. There's so many reasons why we could see a low TANF to poverty ratio. It could be policy environment, which we don't really dig into here, but I just wanted to give you kind of a background on what could be inferred from these results. And this is a snapshot in time, right? And here we have, I believe this was the month of June or July. I'd have to check. But this shows we divided the and I think this was the month where we saw the peaks of the TANF poverty ratios in all of the states, and shows you kind of the geographic or the spatial distribution to show you what those TANF poverty ratios look like. And there are certain states that have very low numbers, and so this just directs you to ask further questions about why there are low rates. So it's kind of like what we call a global analysis, and then say, okay, so we just want to go and dig a little deeper and understand why there are certain areas that have very low rates, right? And it could be a multitude of reasons. We just don't know why, but if we had to focus our study, maybe those are the states we need to be looking at. And the little inset maps on the side show yet another type of spatial analysis. I talked about clusters and outliers, and this is two maps in January and July that shows you low clusters and high clusters. So areas that have statistically significant low values compared to their neighbors and statistically high values compared to their neighbors. So to discuss some challenges and opportunities with the state level data, the opportunities are that they're very easily accessible, publicly available. So you can pull them fairly easily and quickly. They're updated on an annual basis, and you get the entire you get information about all the states across the United States, which is very useful. And you can assess state-based trends in compared to neighbors. And this is a very important part of what we call policy diffusion processes, because policies are often not made in a vacuum. There is research to show that a state will behave or pass a policy and is influenced by its peer states. So states that are around them and with how they pass policy has an effect on another state. So neighbors matter, and thus place matters. The challenges with state level data is the first challenge is what we call the MAUP problem, or the modifiable areal unit problem. What that basically means is when you draw inferences at the state level, they may be very different from inferences that you would draw at the county or the census tract level, okay? So the state level analysis oversimplifies geographic distribution. So if you're truly looking to detect disparities and really understand the impact of place, because place is a very local phenomena. So for example, walkability, job accessibility, all happens within 30-minute drive time, things like that. So you need very fine scale data to be able to truly assess place-based disparities and the connection to outcomes. So like I said, data is too coarse to detect disparities within states. You can't detect things like urban-rural differences, and we know that they're very different. And then the data disaggregated by race is only available annually. And so with all of these challenges, it is very difficult to come up with place-based recommendations, okay? But it's even harder to do people-based recommendations, because we know that people who live in urban areas and people who live in rural areas require very different interventions. They have different needs. So place is automatically a factor in how you would help or improve service delivery. The other study that we are still doing and still refining is to understand racial disparities in job access for TANF recipients, okay? And I call this study Exploring the Spatial Potential for Economic Mobility. So the reason we even decided to conduct this study was because we had done a community needs survey back in the early years of the center when we just started, and we noticed that a consistent theme that emerged from a preliminary statistical model of the responses was that finding high quality jobs was a consistent kind of need for people, and was reported as a challenge, right? So we said, let's investigate this, and look at what the spatial landscape of job access looks like for TANF recipients. We started with high paying jobs because everybody wanted high paying jobs. And I was just talking with one of our other co-investigators, Dr. Comardell, and he said, what's the definition of a high paying job? And I said, well, the census says if you make more than $3,333 a month. And he said, that's not a high paying job. So I'm like, in today's current economic conditions, I think that would totally agree. So we're just looking at, I guess, regular jobs that would give you a living wage. And so I'm also building up here in terms of the complexity of the methods, right? So up until now, we were seeing descriptive methods that involve things like thematic mapping and things like that. But now I'm building up to a more sophisticated approach to understanding access. And this is based on what we call a gravity model, where you're looking at the attractiveness of places, and you're also looking at the competition for those destinations, right? So there's a lot going on here, and I don't want to unpack the formula or anything, but I just want you to know that these are all possible ways of using spatial analysis. And also important to remember that accessibility is a multidimensional metric. It involves a lot of different things. It's financial access, geographical access, transportation access. There's a lot of things, a lot of layers to access. But when we use spatial analysis, it strictly focuses on geographic proximity, and geographic competition, and geographic desirability. So here's a quick graphic to show you what a gravity model does. And it basically tells you, within a census tract, how many jobs are accessible to people and what is the level of competition from other similar workers for those same jobs within a certain geographic distance. So the idea is that you're not confined to the jobs in the county that you live in, but the fact is there are people from other counties that can come and access those jobs as long as it's within a reasonable driving distance, right? So this formula and this access, metric captures all of that. And so we calculated these access metrics and we mapped it. We had to calculate it at the zip code level, and we aggregated it up to the county level. And we calculated two different indices here. One is general job accessibility, and the map on the right shows you job accessibility for employers who specifically employ African American employees. So it's a more realistic metric because not all jobs are accessible to all people just because they're close by. There could be racial biases or discriminatory practices that are getting in the way of hiring. And so what is the realistic landscape of access to high-paying jobs for African American TANF recipients? So that was the motive of the study. And then we looked at for all the states. I'm just showing you samples here. Again, not to make any specific conclusions about the numbers, but to show you how do we detect these geographic distributions. And we know that certain places are doing better than others. So, it draws our attention to these places that are not doing as well. And we want to ask the question, what can we do to help make it better? And again, not to focus on the specific numbers, but we see pretty large differences between metro or urban, rural, and small towns. So we can't detect these differences using tabular data. We can't detect these differences using state level data. We do need finer grained spatial data to be able to make these comparisons. So I want to also present to you a paper that I recently found, and this was very exciting because the author, who's an urban planner, summarized some place-based responses to improve job access, or what we call the spatial mismatch problem, which has been a well-researched topic for a very long time, that particularly looks at job access for low socioeconomic status, so African American workers, right? So there are several reasons that are attributed to this low access, including residential segregation, low skill development, inability to have reliable transportation, so that it's a confluence of many factors. And so this is a great summary of place-based solutions that planners use to improve job access. So we're still, in the process of figuring out how we can use this to connect our spatial analysis with these solutions and make recommendations. So a little bit about the strengths and limitations of this kind of study, right? Strength is that the access measure that we use is a population-weighted access measure, as against more simplistic access measures that are often used in spatial analysis. But remember that it's mostly about proximity and competition. It really doesn't measure the other dimensions of access. So, and the nice thing is we had TANF data by county, which is more granular to understand spatial distributions. We also were aspirational in the study because spatial mismatch study focuses mostly on access to low-paying jobs for African American workers in poverty. But we were aspirational and said, what does high-paying job access look like? And, what do we need to do to move the needle on this? So that was our thought process. But in terms of limitations, access to smaller scales of data is only proprietary. It's not publicly accessible. So you need special permissions, you need funding, you need resources to be able to get access to that data, right? And we would have loved to see the analysis done at the zip code level or even smaller geography. But unfortunately, there's a lot of data suppression at that scale because they don't like to release small numbers because they worry about privacy, and rightly so. So that's a caveat of spatial analysis. This is if you get too fine scale, then there's privacy issues. And even if you try to do this analysis with health data, you're going to run into the same constraints, is they're always worried about privacy. Like I said, access measure only evaluates proximity, does not measure skills or other job requirements. But it does highlight the importance of place and access to opportunities. It is only a measure of potential access. So just because something is close to you doesn't mean you're going to go and use it, right? So it only gives you a metric of potential access, but can guide the development of appropriate interventions in strategic locations. So we can then do very targeted interventions to promote self-sufficiency and economic mobility. And then how do we combine individual level interventions with place-based interventions optimum? That's the real question here. And then, we unfortunately realized that there aren't any feasible outcomes in the ADR of data that we can use to create statistical models. So we're struggling with that still. And so that pretty much wraps up my presentation on some of the ways we are using spatial analysis at the center, and we hope to have some more exciting results to come in the future. So I will hand it over to Dr. Rollins, and I guess we would love to take questions at this point.
Yes, absolutely. Thank you so much, Dr. Rao, for your presentation. I know it was a lot of information quickly for you to digest on spatial analysis. So if you have any questions, feel free to put them in the Q&A box. Also, since we are a small group, if you wanted to just unmute and share a comment or ask your question, you can do that as well. Just let me know. But I appreciate this perspective. Dr. Rao and I have been partners in good for probably about 6 years or so. So before the center was established and things, and so I knew when applying for this opportunity, I wanted to make sure that she was a part because so often when we're thinking about issues that are affecting populations, we often go to the individual, and think wondering, what are they doing and what are they, and a lot of times it is a policy, system, environmental kind of issue that needs to be addressed. And those issues are different depending on where you are, and what you have access to, where you live. All of those things are important. So I have learned over the years in working with her that place and our actual outcomes and well-being are totally connected, and wanted to make sure that we lifted that up in our research at the center. So so yes, thank you again, Dr. Rao, for sharing your expertise with us. So yeah, I think one thing that we have been thinking about. I know in this presentation, we talked a lot about challenges and about some of the issues, but we've also looked at some data sets around opportunities and resources that are available in communities. And I've lifted up the Brookings Institution. They have a index that talks
Yeah.
about communities that are doing well, as it
Mm-hmm.
relates to African Americans and their life expectancy and all the various factors that contribute to a higher life expectancy for Black
Yep.
families and individuals. And so talk a little bit about, acts really mapping the good and things that are going well, how we can better understand those things.
So from a methodological perspective, I think that's where the cluster outlier analysis helps us, right? Because the outliers are the places where you have, like you mentioned, places that are doing well. So they're islands in a sea of places that are not doing so well. And so it immediately draws us to that place and starts making us ask questions about why or what makes that place special, right? So spatial analysis is a way of calling attention to where there's need or there's maximum potential. And you're right. I think the my initial kind of exploration of that index was it doesn't cover the entire United States, right? So it's pretty fragmented. But then that goes back to the data availability question, is because they were merging a lot of data sets. And that's often a challenge in spatial analysis because we have to worry about what we call data interoperability, which means we can have data that comes in at the county level, we can have data that comes in at the census tract levels. How do we put all of these data sets together to tell a story? Right? So I can see that that index that the Brookings Institution published is fragmented for a very good reason, is because there's possibility that some of the data sets were just incomplete. But it doesn't stop us from, like you said, looking at places that are doing extremely well and then ask the question, what's driving that, right? And that is so informative. And I think it goes back to your lens, Dr. Rollins, that you always use, is why are we always talking about the negative stuff? Let's look at the asset-based model where, it's not that just because you have high poverty in a county that they have no assets. There's other types of things, and it's about, we don't do that often enough. And I think it's so important and so critical that we recognize and figure out how to quantify those assets, because it's much easier to quantify, I think, things like poverty, because that's just what the census does, right? I mean, we have the data, but if we have to dig into what are some of the strengths, that's not easily available on a national scale. There's no agency that's tracking that on a consistent basis across the United States. So I think we have some room for some potential innovation there in terms of how we think about it, or develop a pilot or something like that.
Mhm. Especially disaggregated data by race. There may be something that's looking at assets and resources across communities, but our challenge as the National African American Child and Family Research Center that's focused on one population, a lot of
Yes.
times we don't have the data or enough of it,
Yeah.
um, enough of a sample, right?
Yeah.
Just for the Black or African American population.
And I think the other challenge is that we don't have outcomes that we can use to measure. So, I was really looking for that in the ADRF data is, can we say that they have, even if there's a high TANF population in that county, but their health outcomes are really good? We can ask why. What are the support services or systems that exist there that are helping these people and linking them with the right healthcare, and connecting them in ways that they actually need, and we're seeing that reflected in the outcomes. But I think that's again a data integration issue, and I'm hopeful that in future iterations we will be able to look into some of that stuff. And I think the center of Wisconsin, they have, pioneered, I think, some of that stuff. So something to definitely aspire to.
Absolutely. Yes. University of Wisconsin has that data set and those various relationships with state agencies. So
Yeah.
So it's feeding in.
Yeah. But that takes time, right? I mean, to build those connections, you need a politically conducive environment to say, yes, we will share the data with you. And, we want you to analyze it. We want you to tell us what you find, and we're open to knowing the results. And so it's a multi-layered problem. Yeah.
You got one question with our 1 minute left.
Okay.
It said, if you could talk a bit about how using GIS or the data sets to do spatial analysis about the Black or African American community and their needs at the county level would be different than doing it at the state level. So a difference between county level analysis and state level analysis and looking at Black and African American community needs.
So like I said, if you are interested in place-based on sites, the county level analysis is just going to give you a more granular, result, which means that you're not assuming that the distribution is equal across the state. You understand that there are pockets of issues or successes. And you want to get at that. So the county level analysis will tell you that everything in the county is not, everything in the state is not the same. And so that's the only difference. And in terms of the technical pieces, you're going to just have larger sample sizes, and that kind of thing to work with. I don't know if that answers your question, but in terms of the actual methods, they can be used at any scale. They can be even used at the global scale. So if you're looking country level analysis, you can do that too with the same methods.
Yeah, we do see a lot of state data sets that, they do have the information that we're looking for as far as race and those types of things. But what we know is that there are so many differences at smaller scales, even at, various neighborhoods may have totally different outcomes, totally different circumstances. And so typically you want to look as small as possible to see, what differences may exist. So thank you, Dr. Rao. Thank you all who have attended and given your attention to us during this time. Again, please take the survey so that we can know how to continue to improve and provide research resources to you. Thank you all and have a great evening.
Thank you, everyone, for joining us today.
Bye-bye.